Better understanding of the distal esophagus, provided by such newer diagnostic techniques as manometry and pH studies, is leading clinicians to think no longer of hiatus hernia as a single hole or tunnel subject to the mechanical complications of most other hernias in the body, but instead as being a much more subtle disorder related to the reflux and esophagitis that follow. This week on Audio Digest Surgery, Volume 18, Number 19, Hiatus hernia and reflux esophagitis, diagnosis, medical treatment, and the various surgical procedures available, the Allison repair, the Hill technique, the Belsey procedure, Nissen fundoplication, and the Thull procedure. Leading off the program, General Management, by our internist, Armand Littman, of the University of Illinois and the Veterans Administration Hospital in Hines, Illinois.
The symptoms that I would review with you, commonly attributed to hiatal hernia, are really those of esophagitis, and that's one of the main theses that the gastroenterologic internist makes today in this subject. We expect a patient with this syndrome to have heartburn or pain. It's typically aggravated by lying down. It's typically improved on sitting up. It's typically aggravated by spicy, coarse foods. Typically awakens the patient at night, often associated with sour regurgitation, sometimes vomiting, dysphagia, and odynphagia. The word odynphagia is getting fashionable again. It used to be just confined to dictionaries, but with the great amount of research in the esophagus in the last decade, the word odynphagia has been exhumed to refer to pain on swallowing as different from dysphagia, difficulty on swallowing. The urologists don't bother with that nice distinction, but the esophagologists are paying a good deal of attention to it today, and you'll see this word odynphagia quite frequently. About 15% of patients with hiatal hernia across the board have what's considered significant clinical bleeding, and there's the occasional problem of stricture. That is a fair symptomatic review. Anyone, I think, would concur with that. Nothing radical about that. No one would argue about how X-ray will show most hiatal hernias. There is considerable disagreement among endoscopists as to how often they can correctly make the diagnosis with the instruments available. Perhaps the important role of endoscopy is for eyeball evidence of esophagitis, which I submit to you is a major item that we'll be talking about with respect to symptoms. So the endoscopist has an important contributory role. Not every patient with esophagitis, nor with symptoms associated with hiatal hernia, and again I'm talking about the same thing, using these in apposition, will have hyperemia, edema, granularity, friability, vascular injection, and so on. Not all patients who have the clear-cut symptom complex will show a thing on endoscopic study. But recent studies with multiple mucosal biopsies taken by the newer instrumentation do seem to confirm that esophagitis as a pathologic entity fits very well with esophagitis as a clinical entity. One of the things I was asked to talk about in diagnostic criteria was what is the role of manometry? I haven't done it, and I'm not burdened, therefore, by strong feelings about this, as most proponents from my reading seem to be. Using multiple open-tipped catheters placed in the lower esophagus, there are three general kinds of things that can be shown in a hiatal hernia. The lower esophageal sphincter is displaced upward, well above the diaphragm. Intragastric pressures can be recorded in the distal esophagus, and there is a double dip representing inspiratory deflection as the catheter is pulled upwards from the hiatus toward the pharynx. A new kind of study being done now is yield pressure, determining the pressure at which the lower esophageal sphincter can be forced open with water. It is reasonable to expect, as indeed the experiments show, that a lower esophageal sphincter that does not have much resistance to being forced open, that can be easily opened, is one that would have relatively little resistance to reflux. So patients with low yield pressures are more subject to reflux, and the term yield pressure, I think, will be heard increasingly. I want to dwell at a bit of length to the esophageal acid perfusion test. Here's something I have an investment in because the work was done at our hospital about 10, 12 years ago by Bernstein. That's now a long enough period so that it's quite clear that the initial observations have stood up well, and indeed they've been extended, so that it seems clear that what can be learned from perfusing the esophagus with acid is worth knowing about, and I would remark to you that this is no research procedure. Perhaps most of us would think of manometry as a research procedure, although certainly any hospital with a first-class GI laboratory must be set up to study the esophagus with manometry. Perhaps that's more important for other diseases, achalasia, scleroderma, and others. But the esophageal acid perfusion test, I submit to you, is a practical diagnostic test that most gastroenterologists now are set up to do in their office. As a matter of fact, our residents in GI have this bottle set up right at their desk, and they often will do this test while they're talking to the patient about something else, or while they're doing some writing. They may just have these bottles running, doing two things at once in this way. The reason Bernstein developed the esophageal acid drip test is that he was puzzled, as many of us were a long time ago, about why it is that no one had ever been able to reproduce esophageal pain other than with balloons under great pressure by putting acid in the esophagus. Well, the answer is obvious, that unlike the stomach, anything you put into the esophagus tends to run right out. And so it was simply a volume flow business, and it simply took large enough volume of acid dripped into the esophagus to come up with a regularly reproducible symptom picture in esophagitis. The way this test is done, the person seated, plastic tube is passed to the stomach, gastric contents are aspirated simply to be sure that the tip of the tube is below the diaphragm, and then the tube is withdrawn so that the lower end is about 30 cm from the nares. This ensures that the tube is straight and that it is in the esophagus. A 10th normal hydrochloric acid is delivered at the rate of 5 or 6 ml or 7 ml per minute. That's about 100 drops with most setups. And that's allowed to run for 15 minutes. If symptoms are not produced, the rate of flow is doubled for the next 15 minutes. I would point out to you that these setups all have a second bottle, either of saline or glucose, or I suppose tap water would do. And this is all done behind the patient's back so that he does not observe switching bottles. The reason is that one likes to establish that the system is working all right by running in some saline first, and one likes to establish that delivering this rapid rate of flow into the esophagus does not itself cause pain by distension. And so the value of a preliminary control period of 5 or 10 minutes using the saline, glucose, or tap water. And then without patient's observation, the physician simply switches to the acid drip and then observes. Now, a positive test is reproducing the symptoms that the patient complains of. It does not, a positive test is not producing any symptoms. A normal person may get a slight feeling of warmth. He may get a transitory heartburn, but he does not get, a normal person does not get a persistent, painful feeling from this test. Now, by continuing this for a half hour, it becomes clear that if you produce a pain, it gets worse. It does not just temporarily give rise to distress and then go away. It gets worse. And experienced persons have no difficulty whatsoever in a clear endpoint. There is one booby trap in it, and that's that some patients will get pain that they have not had before. Bernstein has called that a positive unrelated test, and it's useful to know that there's a small number of patients who are capable of feeling pain from this acid perfusion that doesn't happen to have anything to do with the pain that they came to see you about. In other words, they have a sensitive mucosa, but apparently do not have, at least under their physiologic circumstances, such a mechanism operating to cause pain. So you must reproduce the pain that the patient complains of to call this a positive test. Now, where such pain is perceived, about a third of patients describe localization at the xiphoid, and another third describe it just a little bit higher. And then there's quite a spread of figures of other sites at which this pain is localized. A few percent of patients have pain in the abdomen. In other words, the patient has complained of an abdominal pain. The investigation didn't satisfy this physician as to the cause of it. Dripping acid in his esophagus may reproduce an abdominal pain. And this is a useful test then for pains other than those that clinically you believe to be due to esophagitis or hiatal hernia. 7% of the patients have their pain in the midsternal area, raising the question of similarity with angina. And indeed, this test is most useful in trying to separate out patients with atypical angina from those with pain from esophagitis or hiatal hernia. The observations on where the pain radiates, where does it go to? In a couple percent, pain goes down the left arm. Alarming, suggests heart disease, but it's quite clear that in a total of about 10%, of patients with a positive test of this sort. Some pain will be felt in the arm, and that should be thought of as part of the complex of esophageal pain. I can assure you that patients who had pain in the arm were studied adequately for heart disease, did not have positive master tests, did not have electrocardiographic abnormalities during the test, and so on. This has been very well studied from the point of view of possible confusion with cardiac etiology of pain. 17% pain radiates to the root of the neck. Again, a symptom tending to make most of us think about heart disease. Some notion of the distribution of the kind of pain that's induced by a positive test under these conditions. Esophagitis may be rather sharply circumscribed. It may have a linear kind of distribution, or it may be felt in a rather large ellipse, and may well be abdominal, either in the midline or to the right. How deep the patient said his pain was felt. Some patients felt the pain way up at the front of the chest, and some in the middle, but none in the posterior half of the thorax. No patient in this series ever felt that the pain was that deep in the thorax. Usually it was anterior. Now, a positive test then establishes the diagnosis of esophagitis. That is, it means that the esophageal mucosa, exposed to a low pH, can reproduce the patient's pain. The pathologic aspect to this syndrome, as I say, has been reasonably well established from endoscopy and now from biopsy. This same kind of information can sometimes be obtained by using acid-barium mixtures. And here, instead of trying to reproduce the pain, you simply look for spasm. The fluoroscopist may see the ingestion of barium mixed with acid give rise to a severe persistent spasm in the lower part of the esophagus. And this is to bring up the point that strong muscular contraction is probably the way in which acid pain is mediated. If pressure recorders are placed in the esophagus at the time the patient is having pain from this acid perfusion test, strikingly high pressures are seen that coincide with the pain, and it may very well be that muscle contraction is the final trigger in pain perception. Test for regurgitation now becomes important. The right way to do this is to have a pH sensing electrode in the esophagus in connection with manometers so that the exact level of the esophageal hiatus can be determined, and a demonstration of an acid pH at any point above the hiatus is considered evidence for regurgitation. Our surgical colleagues were beginning to use this as a demonstration of the effectiveness of their operations, or they had better, since one of the major theses is that hiatal hernias give rise to symptoms only in relation to regurgitation. They will have demonstrated regurgitation before the operation, which is going to be a recurrent theme, or it had better be. Regurgitation must be demonstrated beforehand, and it would seem sensible to expect that if this is true, and there's quite a body of information building up this way, you would then expect that an effective operation could be shown to have diminished or abolished such regurgitation. The point really hasn't been made that you need a manometry pH sensing setup to prove regurgitation. It may well be that simply passing a tube into the esophagus and showing that acid is present may be enough, because under normal conditions you don't get acid out of the esophagus. So any that gets there can be presumed to have arisen by regurgitation, and this point isn't made clearly either yet. Our interest in such regurgitation hasn't been intense or of long duration, but it is reasonable to expect that instead of having pH sensors, simply passing a tube and aspirating and testing pH be adequate. A couple comments on therapy. I'm not interested in operating on a hiatal hernia. I certainly am not. I would like to believe that intensive, skillfully given medical treatment will keep most patients with hiatal hernia away from surgical consideration. And I think because you people are making these decisions all the time, that you must be expert on some of the fine little details on management, because it was my experience in 10 years where I did only practice and dealt with lots of such patients. It was very strikingly clear to me that an intense commitment to medical treatment leads to education on the part of the patient, who may then comply with the kind of program we outline, and it may greatly alter his response to treatment. In other words, as with intensive antacid treatment for ulcer, it tends to work in relation to the conviction of the physician applying it. Now, reviewing this briefly for esophagitis, in the same breath, again, I remind you, hiatal hernia, the aim is to reduce reflux and to reduce HCl. And so the things that any book lists are helping patient lose weight. I never learned how to do that in 10 years. I guess I didn't practice long enough. But you can easily get people to avoid tight garments. It includes belts in men, not just corsets in women. It's a pretty hard trick to accomplish, to get a lady to give up wearing a corset, but perhaps the women's lib movement will make it easier to treat hiatal hernia now. Women's lib, they don't wear the tight garments, everything natural. One, of course, makes an effort to get the patient not to eat before retiring, to eat small meals, and to get the head of the bed up. In raising the head of the bed, it has to be done so that the whole head of the bed is up. It can't be done with pillows, jackknifing the patient. We are against the use of anticholinergics. Here's an important point. One often sees physicians using anticholinergics, and there are at least 3 reasons not to. First of all, they don't usually help, and on empirical grounds, I think they often make the patient worse. But the reasons for this is that they tend to reduce the resistance of the lower esophageal sphincter. They reduce the efficiency of the clearing of regurgitated materials in the esophagus by reducing secondary peristalsis. That is, under the influence of atropinizing doses, the secondary peristalsis that normally clears the esophagus of acid that comes up to it is reduced by atropine. And finally, if you reduce the flow of neutralizing saliva, perhaps you are reducing the helpful perfusion. Such therapy ought to take care of most patients. Admittedly, if you bleed, occasionally you see an ulcer, and I'll admit that such patients are good candidates for surgeons. I don't see a great many patients who are candidates on the basis of intractable pain. Occasionally, we do. But the one additional thing in our bag of tricks is esophageal drip. There's a little risk to this. It's not hard to flood the pharynx with the esophageal drip if it's not carefully supervised. But in our hands, this has been very helpful in the occasional patient whose pain appears intractable.
In the past 2 decades, there have been hundreds of papers on hiatus hernia, with practically all authors reporting good results with their particular method. Operations in use today can be divided into 2 types. First, the creation of an artificial valve between the stomach and the esophagus, as with the Nissan fundoplication and the Belsey and Thal operations. The Belsey, probably the most popular in use today. The second type of operation is the return of the anatomy to normal, as by the Allison repair and by the abdominal approach. One surgeon dissatisfied with the Allison repair, Lucius D. Hill of Seattle's Virginia Mason Medical Center, studied the problem and developed his own method of recreating the normal anatomic situation. Let's listen as he describes his experience.
I thought as a matter of reference we might review some of the anatomy of the gastroesophageal junction as a starting point. The normal anatomy, and I certainly do agree with Barrett that the anterior and lateral parts of the phrenoesophageal membrane must be dissected with an eye of faith. We too looked for this and were unable to find it. So we did some cadaver dissections in an effort to find out what does indeed hold the esophagus in place in the normal subject. The gastroesophageal junction is a remarkably competent functional and anatomical structure. We are convinced from our studies, both manometric studies and anatomical studies, that the sphincter mechanism is the single most important mechanism in the prevention of reflux. There are several clinical situations that support this. In paraesophageal hernia, where the esophagus is nowhere in contact with the diaphragm, and the diaphragmatic opening may be huge, most patients with a true paraesophageal hernia do not reflux, and the only mechanism that remains in these situations to prevent reflux is the sphincter mechanism itself. Manometrically, one can determine with accuracy that the sphincter mechanism does exert a pressure of around 20 centimeters of water in the normal subject, and when held in place and supported by the positive intra-abdominal pressure is remarkably competent. However, when the sphincter mechanism is displaced in the thorax, it is overcome by a rather unfriendly environment of negative pressure in the thorax. The diaphragm now presses on the intergastric pouch, and the net result is that the sum total of pressures working against the sphincter generally produce reflux. We have found a number of large hernias in whom we were unable to demonstrate reflux. Some of these patients who do not have reflux esophagitis may develop an ulcer in the displaced gastric pouch or other complications from simple incarceration of the gastric pouch in the chest. But the objective in hiatal hernia, in contrast to all other hernias, where the sole objective is to simply replace a viscus and close a hole, we do have the other set of circumstances of reflux and restoration of function to as near normal as possible. I think this is the point that surgeons have often overlooked. One may do a nice anatomical repair and replace the esophagus in its proper location only to find that the patient continues to have the same symptoms. The radiologist will tell you the stomach is in nice position, but if he's careful, he may also tell you that the patient is refluxing, and if you do post-operative pH and pressure studies, you may be quite disappointed in what looks like an excellent anatomical repair. A number of workers have shown recently that in hiatal hernia there are two other functional components, namely that the sphincter pressure may be low, and second, that the reflex waves in the terminal esophagus, the peristaltic waves, may be either low or even missing, so that not only does material reflux quite easily into the esophagus, but it may remain there, in contrast to the normal individual where rather powerful reflex contraction waves are produced by introducing acid into the terminal esophagus. Based on some of these assumptions, we went ahead and did some cadaver dissections, again, in an effort to determine what holds the esophagus in place, and we've reported this many times, but it is always interesting how often we are asked by surgeons who do quite a bit of surgery in this area, where is the median arcuate ligament, what is the preaortic fascia, and I thought we might reinforce this point. We've cut away all of the diaphragm and the anterior and lateral parts of the phrenoesophageal membrane, and yet the esophagus cannot be moved appreciably out of its bed in the normal subject. A rather dense layer of fibroelastic tissue extends from the esophagus to the preaortic fascia. The preaortic fascia is simply an extension of a layer of fascia that extends over the aorta all the way from the median arcuate ligament over the celiac axis on up into the posterior mediastinum, almost to the aortic arch. To convince yourself of the density of this structure and the toughness of it, simply go to the next autopsy and put your finger beneath the median arcuate ligament, which lies over the celiac axis, and you will see that this is the central fulcrum from which the diaphragm originates, and it must be stout, otherwise the diaphragm would have no posterior attachment. At any rate, we became convinced that this was the portion of the phrenoesophageal fascial complex that's responsible for holding the esophagus in place in the normal individual. With this in mind, we set about to try and recreate the normal situation. And the operation that we've employed over the past 10 years is simply reducing the hernia, dissecting out the preaortic fascia and the median arcuate ligament, and then retracting the stomach over to the patient's left side. In dissecting out the median arcuate ligament, care must be taken to avoid the celiac axis and the small diaphragmatic branches that go to the crura of the diaphragm. They are usually lateral, and if you stay in the midline, there's no problem. We grasp the cut edges of the phrenoesophageal fascial complex after we have closed the diaphragmatic opening. The crural opening is closed with interrupted sutures so that one can place an index finger alongside the esophagus with a number 18 Levine tube in the esophagus to be sure that it is not tightened down too tightly and thereby producing dysphagia. We grasp the cut edges of the phrenoesophageal fascial complex and first place in a posterior anchoring suture in order to anchor the posterior part down securely. I might say that before we do this, we check the size of the cardia in these people. I think each of these patients may be quite different. Before doing anything further, it's necessary to check the size of the cardial opening. In many of the people, particularly those who have strictures, the cardial opening will be found to admit 4 or 5 fingers. It's quite loose and lax. And unless this is taken into account and unless this is corrected, the operation, at least in our hands, will fail. However, one may find that the sphincter mechanism is quite snug, that it has simply been displaced in the thorax and has failed, and if replaced in its proper location will regain its function. But to make up for this laxity of the cardia, some of the maneuvers that we have been employing, after taking the posterior stitch, we take an anterior stitch in the phrenoesophageal fascial complex, including the seromuscular layer of the stomach. We take these quite deeply, We do not dissect these with an eye of faith. If one cannot get a good bit of tissue here, then again, one must go deeper in order to include enough tissue to make a strong suture. We avoid the esophagus assiduously. We have had 2 perforations of the esophagus now. We are unable to explain these because we've avoided the esophagus like poison, but still we have had 2 perforations in a series that now is around 470 cases. But we take these sutures in the anterior and posterior cut edges of the phrenoesophageal fascial complex in such a manner as to imbricate the lesser curvature and snug down the cardia to where we can feel the cardial opening barely admitting the tip of a finger alongside a number 18 Levine tube. To do several things. First, to make certain that we're not tightening it down so tightly that we are going to produce dysphagia, but even more importantly, to make sure that we have overcome the baggy cardia that these people often have and which allows them to reflux postoperatively. The number of patients that we've studied postoperatively now is around 250, and the small number of these patients who show persistent reflux represent, in our opinion, a technical failure to replace the sphincter in its normal location and to support it properly and to calibrate the cardia after the sutures are tied. The completed procedure, a segment of intra-abdominal esophagus, which we believe is quite helpful in the prevention of reflux. The positive intra-abdominal pressure helps support this. The sphincter is in its normal location, or actually a rather exaggerated. The sphincter normally would be up in the hiatus, but here it's down around the median arcuate ligament. The sutures have been tied, and one can palpate the cardial opening through the stomach wall, and the opening barely admits a finger alongside the number 18 Levine tube. We have employed this procedure in a number of patients, namely around 50 now, who had the most serious complication of esophagitis, namely stricture formation. So many controversies have arisen in regard to strictures of the esophagus. This is the kind of stricture that you see reported throughout the world literature and referred to as the short esophagus. If one biopsies the esophagus distal to the stricture, one does find that there is gastric mucosa. In performing manometric studies on these people and during the course of dissection at surgery, we became quite puzzled because we could see that the phrenoesophageal fascial complex was down just above the diaphragm, that the stricture was at the squamo-columnar junction, that tubular esophagus was lined by gastric or columnar epithelium, but it appears externally to be tubular esophagus. We wondered then if the esophagus was truly shortened, and we wondered where the sphincter lay in such a complex as this. No one had really looked for the sphincter before. It had been assumed that the esophagus was shortened, but if one accepts the sphincter mechanism as the dividing line between the esophagus on one hand and the stomach on the other, just as we do the pyloric sphincter separating the stomach from the duodenum, we must conclude then, if we can find the sphincter, that that should tell us whether the esophagus is shortened or not. We have applied a different type of technique to these people in that we dilate the stricture with one surgeon working from above with a dilator. The surgeon working from below straightens out the esophagus, which facilitates dilatation and then guides the dilator through the stricture. This is very important, otherwise perforation of the esophagus by this maneuver is something that might occur. Some of these strictures have been so-called undilatable strictures. Several of these people in this series had come to us because their stricture could no longer be dilated by simple dilatation from above. We therefore believe that the term acquired short esophagus has misled us as well as other surgeons into doing rather large and formidable procedures on what is a benign condition, and if one is careful and applies the operation to the individual patient and makes sure that reflux is stopped, and this is a big if reflux is not stopped, the stricture will persist. I'd like to emphasize again that if one does not calibrate the cardia and anchor the sphincter properly, this operation, like many others, will fail. But if one is careful and pays meticulous attention to details and the sphincter mechanism is placed in its proper place, reflux, by and large, will be stopped.
And this, Doctor, is the end of Side A of this program on hiatus hernia and reflux esophagitis. Side B, with discussions of the Belsey procedure, Nissen fundoplication, and the Thull procedure, can be heard by just flipping over the cassette or 2 reels on your tape recorder. Side B, Audio Digest Surgery, Volume 18, Number 19, continues a program on hiatus hernia and reflux esophagitis. The next man to the microphone, Harold C. Urschel of the University of Texas Southwestern Medical School, discussing the Belsey procedure.
From the point of view of evaluation, our approach to the problem for evaluating patients has been the cineesophagogram in the first 200 cases, correlated with pH and pressure studies, acid infusion studies, esophagoscopy in every case under local, sitting up with a full stomach to evaluate reflux. It's the way Mr. Belsey has done it for many years. And then an adequate evaluation of the pylorus for outflow, because in our cases of recurrence, the biggest problem has been people that have had distal obstruction unrecognized prior to surgery. Postoperatively, our patients in that group were studied by the same techniques for the first 200 cases, and we then changed just to using the cineesophagogram, which is much more acceptable to people, and then they're evaluated 3 months postoperatively and every year thereafter. What the Belsey procedure is, it involves the principles that Dr. Hill mentioned, getting a segment of intra-abdominal esophagus to take advantage of the positive pressure, the reconstruction of the normal gastroesophageal angle into an exaggerated position, and closure of the hiatus, which is really not a part of his repair. The approach that we've used is a 7th interspace on the left through the chest, can be done through the abdomen. Mr. Belsey uses a 6th interspace because of pain. Esophagus is free to the aortic arch, leaving the blood supply and vagus nerves intact, but allowing for extra length of the esophagus, because the thing that in his repair is important also is that the esophageal sutures are the weakest aspect, and there must be no tension on the esophagus lying in the position below the diaphragm. The first layer of sutures goes from the esophagus to the stomach, approximately 2 centimeters above the cardia in the esophagus, and about 3 centimeters to 4 centimeters below in the stomach in radial fashion. Vagus nerves are behind, so that it goes from vagus to vagus, and the posterior part to the right of the esophagus is never touched by sutures. Therefore, there's no problem with dysphagia in this operation. Now, important also in this is the recognition of people. Whether or not a hiatus hernia is present is insignificant. The problem is whether or not they reflux, and a patulous cardia is just as severely, critically important as a hiatal hernia with reflux. Now, we've employed a modification called a callus gastroplasty in certain cases of just reflux, but more often in stricture cases, as Dr. Hill mentioned. We'll talk about that in a minute. But in certain cases where the esophagus is difficult to bring into the abdomen, to get enough length to assure a good repair by this technique, we simply slit the stomach, elongating the esophagus with the gastric tube. Then a Belsey procedure is done on this situation, reestablishing a new cardia. We've tried in most cases to bring the cardia into the abdomen and do our repair. It's possible, as Dr. Thull mentioned, that you can have a reconstruction in the chest that will be competent, but in our experience there are less satisfactory results than if we can get the cardia below the diaphragm. Now, the symptoms that we're all familiar with and have been discussed with regard to the esophagus, we're familiar with these. Some that we're less familiar with are those related to the pulmonary tree and include bronchitis, recurrent pneumonitis, laryngitis, asthma, diffuse interstitial changes, caseating granuloma, bronchiectasis, and abscess. Now, Mr. Belsey pointed this out in '52. We're perfectly willing to accept complications of achalasia of the esophagus or stricture of the esophagus with reflux and aspiration, but we don't think about these situations in the situation of a patulous cardia, which can do the same thing with regard to reflux. The pharyngeal sphincter has to be incompetent in sleep or with drugs, and then the cough reflex also has to be subdued in order to get this kind of symptomatology. The change in our practice is possibly because of our referral situation. I don't think is representative of the country, but before 1961, 13% of the operative cases were pulmonary predominantly. Subsequent to that time, 60 of them, 20 pure pulmonary without esophageal symptoms, and this is where you have to have a high index of suspicion, and then 80% with some esophageal component to give you a lead as far as the diagnosis is concerned. Now, in the esophagus, we have objective methods of documenting reflux. In the lung, we have no objective methods of documenting aspiration. So the diagnosis is made by exclusion, by suspicion, and by medical treatment to the point that the patient is not a success, and then a reconstruction of his gastroesophageal angle. But this is one of the areas of the future, I think, is to determine the objective methods of aspiration secondary to a gastroesophageal reflux. Bronchiectasis in young people, the cardiac mechanism develops sometime before the age of 12 in most patients. The infant and the young child have free reflux. We don't understand this development with regard to physiology, but before the age of 12, they have a competent sphincter in most patients. But we haven't yet seen a child with bronchiectasis in their teens that has not had significant massive gastroesophageal reflux. Now, our results with modified Allison, the 8 to 10% reported by Dr. Sweet, but the significant factor isn't the hernia recurrence, it's a matter of reflux recurrence. In the Belsey operation, we only had 1% recurrence of the hernia, but we've had a 10% recurrence of reflux, and we used to think that this occurred in the first 3 months, 6 months. Now we know the longer they go, the greater the recurrence rate, and it's now up to approximately 12 to 15%, and in a group of patients about 1,000. So that reflux is what we're talking about, not the anatomical hernia. Now, Skinner reported the American Surgical this year, pH reflux study and acid clearing tests on a group of patients studied preoperatively several years ago, followed and restudied prior to this presentation, and demonstrated various types of hernia repairs with the reflux test and the pH, which we think is one of the best postoperative evaluation tests, and then the acid clearing test. We found in a group of 100 patients that had elevated gastric acids but no ulcer that when the hernia was repaired or when reflux was corrected, their acids reverted towards normal without any vagotomy or pyloroplasty, and we reserve this procedure for patients with pyloric obstruction, previous ulcer disease, or stricture, and use it selectively depending upon the individual case. Now, with regard to the complication of an annular stricture, we feel that all types of strictures are ends of spectrum of reflux and scarring, healing, and so forth. And it can be an annular stricture, or it can be a longitudinal stricture, it can be ascending stricture. Always, as Dr. Hill mentioned, below is columnar line tube, above is squamous esophagus. In this type of stricture, we've employed a gastrotomy just below the cardia transversely, bring the stricture into position, excise it. It involves the mucosa and submucosa in most cases, and then bring the mucosa down to the gastric mucosa by suture. You can dilate this and rupture it and do a good reflux operation. It's just as successful as a careful surgical dissection. For the longitudinal stricture, we've dilated this, as Dr. Hill mentioned. We've done, in some cases, a callus gastroplasty to allow us length on the esophagus and then a good reflux repair. And in this case, Pearson reported his results over a period of 5 years at the American Thoracic, and you have to dilate patients postoperatively as well, anywhere from 1 to 10 or 15, 20 times, depending upon the situation and the length and the degree of stricturing. But as long as you prevent reflux, you'll get a good result with stricture. Now, if you just dilate these strictures, you get relief of dysphagia, but you perpetuate the reflux and continue the process. Now, when the stricture is up, we have used colon interposition as the procedure of choice. I think that Dr. Hill's comments are good, and I think there isn't any reason why you couldn't dilate that and do some sort of a reconstruction at this point in certain cases. We've chosen to use the colon in the high stricture. The dilators have changed our life as far as the simplicity, the Maloney dilators, and I would recommend them to you for ease and patient comfort. I think that, again, the main asset here is to appreciate the physiology which was pointed out to us by the English, and to make whatever repair you use by whatever approach that you want and selected by the individual patient to stop reflux, and then to study the patients in your own hands. Very well to look at a Belsey operation or a Hill procedure and see his results, but these don't mean anything to the individual. We've done about 25 Hill operations when we've been in the abdomen, or modified Belseys through the abdomen, and unless you study your patients in your own hands, you're not going to know how this operation is resulting, and you're going to see your good cases, your bad cases are going to somebody else. And again, the value of Mr. Belsey's work, he changed to the Mark IV about 59 or 58, is that other people have looked at his results and not him. Other people have looked at our results, and I think that it takes a lot of time, as Dr. Hill mentioned, to evaluate any procedure. This is time proven. It's not perfect. You can't belch after this procedure is done well. There are certain disadvantages to it, but the patients are eminently grateful.
Before elucidating the indications, techniques, and operative results with Nissan fundoplication, Hiram C. Polk, Jr. of the University of Miami School of Medicine offers this preface.
The work that I'm reporting is work that Dr. Zepp and I have done together over 5 or 6 years, and it comes from a fairly large medical center with about 2,400 beds. And I ask you to reflect in part on the fact that we're talking about a group of only about 80 cases. And I think this means something in terms of selection of patients for operation when you see in a medical center this size, which is substantially larger than that of my colleagues who preceded me on the podium. We have felt that we found relatively few people who warranted operation for hiatal hernia. Secondly, I would point out that in this series, this represents a little better than 90% of all operations done for hiatal hernia in this medical center. In other words, we are doing by far the great majority on our staff service and our own private service. And that fully half of these operations have been done by resident surgeons and not by the attending faculty or by the individuals that help to develop the techniques. So I want to reiterate that this is a very selective experience. The other thing that I should mention is that no other operations for gastroesophageal reflux or hiatal hernia have been done on our service. All the patients who've had operations have basically had Nissan's fundoplication as the critical part of the operation. Our indications for operation, we depended in this situation on esophagoscopic evidence of esophagitis. And we found that the great majority of our patients had reflux esophagitis as an indication for operation. A portion of them had another illness somewhere that warranted an operation at the same time. The frequency of lower esophageal ring is relatively low, esophageal strictures low, suspected carcinoma and other lesions only, and that includes one patient with what we thought was respiratory complications. Now, there has been a great deal of heat and not much light generated by discussions of what route should be used in the repair of hiatal hernia. We felt that this has been very easy to define for each patient. And so every patient that we would consider for operation has had several studies done. First of all, an esophagoscopy, obviously an upper GI series, which has been complete, looking for coexisting duodenal ulcer disease. Most of the patients have had barium enemas, and all of them have had oral cholecystograms. We have then felt, on the basis of this indication, that we could choose to perform a transabdominal or a transthoracic operation as indicated in the particular patient's situation. The surgeon's choice of a route of operation was involved in relatively few of these procedures by the transabdominal route. In other words, out of this group of patients, a little more than half of them had clear-cut evidence of biliary tract or ulcer disease which warranted operation, and we felt this was a pretty clear indication to go ahead with a transabdominal operation. There are other abdominal hernias, and we did consider the presence of severe emphysema as an indication for an abdominal operation. In the absence of blebs, it might warrant resection, and the previous use of a transthoracic repair. The group of patients which have had the transthoracic operation, we feel ordinarily that significant evidence, radiographic evidence of esophageal shortening, and we agree with what's gone before, this is seldom true shortening, makes the operation technically easier to approach it transthoracically. Some people have had pulmonary lesions resected at the time of transthoracic operations, and there have been previous abdominal repairs that have failed. Again, the frequency of patients having operation through the chest because of the surgeon's preference is extremely small, and this is in the absence of other indications for operation by one route or the other. I want to briefly run through some of the techniques with the Nissan operation, which, as Dr. Urschel has indicated, has its origin in Europe with Professor Nissan in Basel, Switzerland. And this is the problem as one approaches it and reduces the hernia by traction from the transabdominal approach. The first thing here is obviously to incise the peritoneum overlying the esophagus and mobilize this as we all do for transabdominal vagotomy. And the transection of the gastrohepatic ligament for all of the operations carried out through the transabdominal route is absolutely essential to provide the exposure that we all need here. I think there's no question that one of the contributions to the relatively good success rate we've had with the Nissan operation has been that it demands an extensive, meticulous dissection of the gastroesophageal junction. And the view provided is unexcelled in every case, and it's very common for the resident doing the case to say, I've never seen this before. And I think this is often the case in someone who's done probably more than 100 vagotomies. This is an extensive dissection of the area involved. And we always append crural suture to the operation. We think that this does no harm, probably does some good, and it is included in the transabdominal operation prior to fundoplication. Now, some of the problems of the Nissan operation. You must sufficiently mobilize the upper portion of the stomach, the cardia of the stomach, so that you can, working with your right hand, pass the stomach around behind the esophagus to accomplish the fundoplicating sutures from point A to point B. And this is a critical consideration. You must have sufficient mobility to do this. The short gastric vessels are not really a problem, and you can do this with ease. I think in fewer than 4 or 5 cases have we ever had to transect the short gastric vessels to get this mobility. The biggest problem here is adhesions to the pancreas posteriorly and to the diaphragmatic crura. With the very satisfactory position, with your right hand holding this in place, it's very easy to place the sutures left-handed and provide a very secure plication. One of the things we like about this, of course, is that rather than depending on diaphanous structures about the cardioesophageal junction, we're sewing seromuscular gastric fundus to seromuscular gastric fundus with a few tacking sutures to hold this around the esophagus where it doesn't slip off. Transthoracic repair is basically the same thing. Standard approach here, of course, we dissect the hernia sac clean, mobilize the stomach thoroughly, and we carry out the fundoplication before crural suture. Having accomplished this, we will then tuck this down in the abdomen and repair the crura. Emotionally, and on the basis of 1 or 2 patients, I'm convinced when you're dealing with a short esophagus, you can leave this in the thorax and maintain just about as good a control of gastroesophageal reflux in a case of true short esophagus without going to the trouble of the callus gastroplasty or extensive mobilization of the esophagus. Ed Woodward also has some data that indicates that this will maintain competence even when left in the intrathoracic position. And then the procedure being completed with crural suture. Now, this operation has, in our hands, been relatively successful. Let's look at our immediate results. The significant complications that have occurred in these patients, dehiscence and evisceration of phenomenal frequency of something like 8%. This was all related to individuals who had extensive operations intra-abdominally concomitant with hiatal hernia repair, and that's an unfortunate frequency which will probably decrease as our experience continues. It certainly is a major complication. The principal complication we've seen in the transthoracic operation has been that of intercostal neuralgia, and that's occurred in only 2 out of 26 patients. The other thing that I should mention, and in this group of patients, there has been 1 postoperative death. Now, it's obvious that the technique is one which can be readily learned. It's an easy technique. There's not a great deal to it. That this is associated with, in our early experience, some high complication rates that I think are more related to concomitant operations than to the procedure itself. However, they do exist. Now, our real problem is this operation a step forward in terms of long-term control of esophageal reflux and esophageal irritation, esophagitis. And in the early stages of this procedure, we performed cinnobarium swallows and esophagoscopy on every patient at 3 to 6 month intervals following the operation. Now, 2 things happened. One, these people who remained well got tired of this and refused to come back for continuing follow-up, even in a situation where we had relatively good control of the patients. And 2, as the years passed and the frequency of recurrence of esophagitis remained extremely low, we have accepted barium swallows and barium swallows as adequate follow-up. Now, let's look at the first patients who were done, those that have been followed for more than 5 years. Early in the course of their follow-up, almost all of them had esophagoscopy. To clarify this, we ran into a combination of our own satisfaction with the absence of reflux and the patients not being interested in continuing this, though we've continued with a high frequency at intervals of barium swallows to see that the patients maintain no reflux. As demonstrated, we have not been able to convince them that esophagoscopy is warranted, and I must admit my own enthusiasm for its necessity has declined as the procedure has seemed to maintain its good results. Then in the intermediate group, which have now been followed up from 3 to 5 years, we see the kind of pattern in which almost all of them have been studied by barium swallow. Many had esophagoscopy early, but again, as this is followed on later, our enthusiasm and patient reluctance has kept us from carrying this out as frequently as we'd like to see. Finally, the recent group is really not significant in that they've all been studied early post-op, but the number having esophagoscopy is very low. Now, the proof of the pudding is not only how we follow them, but how many of these patients have recurrence. We have 2 patients with anatomic recurrence in this small series, and only one of those patients has reflux. So I think these results in a fairly carefully studied group of highly selected patients suggest that if your patient has esophagitis, if he needs an operation for hiatal hernia, and if you should choose to carry out this relatively easy technical procedure of Nissan fundoplication, either by the transthoracic or transabdominal route, you can expect that patient to be well and remain well and basically stay free of reflux esophagitis.
Our last discussant, Alan P. Thal of the University of Kansas School of Medicine, outlining the Thal procedure.
I will confine my remarks to the problem of severe degree of stricture, and like Dr. Polk, our experience with this problem extending through large numbers of patients with esophageal problems is really limited to a very small number, considering the potential group who actually required a definitive operation. And I think this is important because, just as pointed out in the initial talk, very few patients with hiatus hernia require operation. So do very few patients who have a so-called stricture need extensive operation. Many of them respond to milder methods. The type of case that we're talking about, whether one chooses to call it short esophagus or not, constitutes a very severe degree of obstruction and usually has the history of having had multiple operations previously, ulcerations, occasionally perforations by the dilator, and ultimately reaches us after a period of about 5 or 10 years of unsuccessful treatment, at which time the patient is usually in the late 60s or even in the late 70s. And then at operation, one finds that the stricture may be high, and I think it would be pointless debating whether this segment below the level of the stricture is esophagus or stomach. I don't think we can really settle it at the moment. I think perhaps Dr. Paul Jordan work from Houston is the most definitive in this regard with his motility studies, supporting the fact that this may be a differentiation of the mucosa of the esophagus and that this is not actually true stomach. In any event, the stricture may be quite high, and on opening into the stricture, one sees a gastric type of epithelium below and extreme degrees of scarring above, marked muscular scarring, a hypertrophy of muscle, ulceration, metaplasia of the squamous esophagus, granulation tissue, and really quite a severe degree of esophagitis. The approach we use is similar to that described by all the other authors, approaching the esophagus from the chest through the 6th or 7th interspace, the incision in the esophagus, an effort to translate the available tissue into a satisfactory posterior wall by approximation posteriorly, and then the application of the stomach as a patch graft to secure the first objective of treatment, which is a wide channel through which the patient can swallow. In severe degrees of esophagitis with severe scarring, marked muscular scarring, which is perhaps brought about by repeated dilatations. We feel that applying a split-thickness skin graft here offers us immediate reconstitution and lining of the esophagus with less chance of subsequent scar contracture. The next part of the operation is absolutely crucial and again refers to the point stressed over and over again, the formation of an adequate valve. And I would like to propose that the rather cumbersome and perhaps uneuphonic sound of fundoplication be replaced by what is really a term which expresses our objective here, and that is a fundic valvuloplasty. Regardless of the way it's achieved, the general principles are very similar. The ultimate results are very similar to those described by others. And probably the question of whether they function or not depends not on the name applied to it, but depends on the basic physical principles involved in the formation of the valve. And this is what is important. The patients we've seen who've been subjected to this operation have very frequently simply had the stomach applied to the esophageal defect. While this reconstitutes the tube, it has no effect on reflux. In order to obviate the reflux, it is necessary to incorporate or invaginate the esophagus in one way or another, partially or completely, into the positive pressure gastric bubble and subject it to that pressure. This is the basis by which this operation works. There may be some question, this hasn't been fully worked out, whether the Nissan works entirely this way. It's possible that simply by suturing completely circumferentially, one provides a muscular obstructive mechanism preventing reflux as well. But largely, it's probably due to the positive pressure in the intragastric bubble, the negative pressure within the esophagus, and the transmission of this pressure in the esophagus invaginated in the stomach. We feel that leaving a small segment, I point out again, it's a very small segment of the posterior esophagus free, obviates what has been quite a problem with us, and I think with others, where we have incorporated it fully, and that is the inability of the patient to belch. And some of these patients complain of very marked distress, inability to belch. It may not be a minor problem at all. We have one patient we actually had to train to swallow a nasogastric tube so that he could relieve himself of the severe gaseous distension, which can be very marked. Now, we feel that this sphincter mechanism of valvuloplasty functions very adequately in the chest, where one has transmission again of intra-abdominal pressure, although, as has been pointed out by others, certainly the best functional development is when the whole mass can be reduced into the abdomen. And another point that I would mention is that we always do this operation with a large number 50 dilator through the esophagus, just to prevent any immediate possibility of narrowing of the esophagus at operation. In the absence of esophagitis, very rapid healing takes place. This is our total experience now, extending over about 7 years, and this includes cases done by my colleague, Dr. Hatafuku, in Sendai, Japan, 23 cases of acid peptic stricture with 1 death, 19 good results, 3 poor results, one of which turned out later to have scleroderma. And the operation, the identical operation, has been used in achalasia in 6 of our cases and 19 of Dr. Hatafuku's with really excellent results. Several of these cases have been reoperations, Hellas, followed by reflux, and those complicated cases where there were both motility problems and reflux. Post-emetic perforations, we've had 6 with 5 satisfactory results. All of these have been operated upon 24 hours, at least 24 hours after perforation. 2 post-traumatic defects, 1 large leiomyoma. 2 patients with esophageal varices have been approached using this type of reconstruction. So I think what we really need to do is not to emphasize the differences in these various approaches, but to assemble them now and to pick out what's good in each one, to try and evaluate them physiologically so we understand the basis, to recognize that the ones that work really have a lot in common functionally, and to apply the right operation to the right patient, to recognize that very few of these patients actually need operation.
And this concludes this 19th edition of Audio Digest Internal Medicine for 1971. Our thanks to all participants and to the Board of Regents of the American College of Surgeons for cooperation in recording and disseminating this material. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.